Now, I am actually addressing the House officers, although I have given the homework to discuss the case number 1. Very few people were interested in these presentations. Although I am, continuing my discussion with the case number 2 now. Whether you are taking interest or not, it is here for own benefit. I don't know. Why the people are not interested, I don't know. Whether I am not doing on the correct path or not, I don't know. The thing is this, we have to, doing our best. If you will participate, that's all right. If you do not participate, then of course it's your own wish. I don't want to comment. I am Professor Ali Haider and I am Global Honorary Professor or Imaginary Professor of Medicine without any fame or any economics in my career. That is the aim of mine. On the correct path. Adhan Sirat al-Mustaqim means correct path. Now this is the presentation, that is. It is a 56-year-old smoker. He smoked about 30 cigarettes per day. He is known diabetic, and he claimed to be a controlled diabetic, presented with the orthopnea, hypopnea, with anasarca since 10 months. Anasarca, what do you mean by anasarca? It means the whole body is affected with swelling. And for the anasarca, it should be 3 separate parts of the body should be affected. This is the definition. Now, its duration is 10 months. It is a progressive type of a problem, admitted in the medical ward for evaluation. Now, he is orthopnic, can't lie straight on the bed, and cannot lie on the one side of the bed. That is called tepapnea. Tepapnea means he cannot sleep while he was sitting on the bed, just opposite to it. That is tepapnea. These are the things that all parts of the body are affected here, the face and the limbs, the actual parts. Now take the history of presenting illness. The patient was fine about 10 months back, although he was known. Always remember, you should describe the comorbid first and then start it in your presentation. Before going with the biodata, in the end, you should write whether the patient has the comorbids or not. This is very important point. The thing is, you start the history with taking the history of the presenting illness. The patient was all right 10 months back when he developed these type of the complaints which I have just written in front of you. And it should be like this, because he had arrived with a severe breathlessness, tried to describe this breathlessness, and then go downwards. That since 4 months he developed the other parts of the body which are affecting, and like the face. He started with the limbs or with the face, and this is the problem with this patient. Basically, the problem is breathlessness, and when you are describing this breathlessness, very detailed account should be taken, including the paroxysmal nocturnal dyspnea, and that is very important clue to the diagnosis. So he has the paroxysmal nocturnal dyspnea, all right. In this patient, he will give, if you ask, he will give the history. For the paroxysmal nocturnal dyspnea, I want to take separate class, because this is the terminology which is rather cannot be cleared without discussion. So, paragraph should be written here, in your case, which is admitted in your ward. And then in the end, if you are doing in the end, you do another thing, and that is what I will want to emphasize is that you should classify the breathlessness patient in the classes, whether severity should be described in the mild or moderate or severe, or it should be described under New York Heart Association and by HA classification, class 1 and class 2 and class 3 or class 4. It should be described like that. You should learn from the book, because the time is short. I cannot explain the NYHA classification of breathlessness. And then you take the past history properly. It should be proper history. And you go for the family history. You should know how to take the family history. You should go to the personal history and the socio-economical history. In the past history, in this patient, nothing, but he was all right 10 months back, but he used to come with the cough, and very mild cough, although it is, and intermittent fever, often off and on, since 2 to 3 years or more than that. In the past history, it is the past history, not the presenting complaint. And the other history should be taken with the past. The family history, that his father and the brothers, they are suffering from the breathlessness, but they are smokers of the different categories. The personal history, that he is by profession, he is doing it, a businessman who is running a factory, small factory, where the chemical agents are used. He used to make the chemicals, and the other things in the personal history you should remember, that it is personal, means that the whole body should be asked. It's a systemic review. In my opinion, systemic review should be done in this. You ask two questions from every system. And the socio-economical history, he is a well-off person, and he can afford the advices you will give. And there are history of pets in his house. He has grown what is called poultry in the the highest part of the building. He has 4 first floor, second floor, third and fourth floor building. And there he has also had the buffalo in his ground floor. This should be written in this. And there was a history of he had gone to the 3 to 4 times outside the country for the business matter. Since about in 10 years he was visited different parts of the world for the order or for the business. This should be written also. So he is a smoker, all right. Therefore, the smoking should be described slightly detailed in the personal history, other than the marital problems and other problems as well. And then we go for the differential diagnosis on the basis of the history. The patient was a smoker. This is the hard data. He's got breathlessness gradually mounting up. Swelling is starting with on the limbs, and then spreading all over the body. Now this is the first one, is the congestive cardiac failure. And usually in cases of the renal diseases, if there is an asaka with breathlessness, and with the breathlessness, the swelling appears first on the face, around the eyes, and then on the face, and then the limbs, and the other parts of the body. It is the reverse of it. So one is congestive cardiac failure, that is going into the biventricular failure. And the primary cause, probably because he's a smoker, I assume that he had developed in your presenting history, the cor pulmonale. And cor pulmonale may be acute, it may be recurrent, or it may be chronic time. So he had developed cor pulmonale before, and there are recurrent cor pulmonale, and now he developed the chronic type of the disease, because it is the patient has been suffering from a disease which I don't like, this disease. That is the obstructive diseases of the lung, one of the obstructive diseases of the lung. You know that this is the hot topic going on in the world, the obstructive diseases of the lung. Then that got with diabetic nephropathy, and nephrotic syndrome can cause this this disease, this presentation is possible. Underlying the chronic liver disease may be possible, hypothyroidism is possible, hypoproteinemia is possible, adult kwashiorkor. It is rare although, but it is possible. So these patients are, COPD patient, probably in my mind. I don't know what is in my examination, that he is suffering from the copulmonary, which leads to the congestive cardiac failure. Underlying diseases which are enhancing the problem will probably with the compromisation of the kidney because he is diabetic, probably. And these diseases should be least possibilities because there are no peripheral stigmata which is described by you, in your observation. The do GPE without missing any physical sign. You have to go to the vitals, 99 degree Fahrenheit temperature, pulse 108 per minute, low volume, regularly irregular. Regularly irregular. Why? You should answer in the end why it is regularly irregular. The BP is 90/67 is low blood pressure, and respiratory rate is 26 per minute is high one. In this patient, maximum respiratory rate should be 20 around. So it is tachypneic. And there is a fifth vital as well, and it is the pain assessment. This is the addition by the American College of Physicians. You ask the fifth vital. Pain should be experienced by the patient in any form. The pain is out of 8, because there are 8 or 9 or 10, but he is in between 7 to 8. So 7 by 10, you can say. Out of 10, it is very, very severe one. It is around between 7 to 8. Pain. He experienced pain in the chest and the surrounding area because of the severe breathlessness, because of the fatigability possibility. But this sign, the fifth vital, is important if you are going to the United States for further studies. In these countries also there is sixth vital also. And sixth vital means that how much health awareness has been achieved by the patient, whether he knows his disease or not. This is the sixth vital. Health education has been given to this patient. Preventive measures have been taken by this patient. So I give him 0.5 out of 10. If I make this one, no marijuana, etc., and the lower down and then going up, escalating to 10. But he is a very, very knowledgeable person. He knows everything. Although he was smoking, but he knows the circumstances of smoking. And although advices has been given by the doctor previously, this is sixth vital, described by the American College of Physicians, endorsed by the WHO. Yes, it should be. And seventh vital after coronavirus is SpO2, saturation. Because it is the examination by hand, it should be done. So pulse oximetry, you have the pulse oximeter with you. SpO2 88% is less than 90%. BMI was 37. It is the moderate type of the obesity. The upper limbs, nail clubbing, grade 2 with nicotine staining. Capillary refill time was more than 2 seconds. Refill time. It should be less than 0.51 second. It's more, he is taking more time. Cyanosis is positive. The cyanosis in the upper limbs, in nails, are clubbed as well as they are slightly, tinge of the purple color. Flapping tremors was induced tremors and they are positive. Epitrochlear and the axillary lymph nodes, they are negative, because I am doing this examination from the upper limbs to the neck to the face, etc., then going down. How important it is, and you see this. The face is tongue coated, bad mouth, hygiene, central cyanosis also present. So the peripheral cyanosis as well as central cyanosis is present. Indirectly, you said the SpO2 is 88 or 87, it means that he will develop ultimately cyanosis. Nose, throat, scalp hair, normal, eyes dry, they are dry eyes, and bilateral pterygium, although it is not related with the disease, but it is incidental finding, because he is working in the chemical industry. You can say indirectly. So it may be possibility that it results from the, and there's a very, very hot atmosphere there. He developed pterygium. The ears are normal. The neck, the nose are normal, ears are normal. So ENT examination with eyes are normal. As the face is concerned, there is edema. This is what is shown here is slightly tinge. Here capillary filling time is delayed in this. And in the capillary fill time here, the patient has got grade 2 type of the clubbing. The angle is gone in this condition. And window test, which you're doing the Schimmel's test, or the other test, which is you are doing, is positive in this case. So this is the clubbing. Clubbing should be demonstrated in front of the examiners. It is grade 1, it is grade 2, grade 3, or grade 4. At the refill time, you press the nail and just let the hand free. Then this will refill in your case in less than 1 second, or rather 1.2 seconds. Here is more than 2 seconds. It's delayed refilling because of the poor cardiac function, probably. Neck, thyroid, no visible palpable goiter, jugulo-omohyoid, jugulo-digastric, supraclavicular, suprasternal, submandibular, retromandibular, retroauricular, occipital group of the lymph nodes not palpable. Like you should write in this fashion. And what you will do doing is that the lymph nodes are not palpable. I don't want this. The neck area should be examined for the tracheal tug. In tracheal tug is a specific sign. What is tracheal tug? You will answer in the end. The tracheal tug is a bad sign. It is leading to the respiratory failure. Neck muscles were in contraction and hypertrophied. Neck means they were prominent. And torso means trunk, no pigmentation, bilateral, non-tender, gynecomastia he developed. Why developed? Answer. These are the questions I will put in the end, and you will do your homework and then answer me. Abdominal muscles were in contraction, and subcostal recession will be there. The extra pulmonary muscles are in action. Now here you see there's a tracheal tugging, sign is positive. Here is the jugular neck veins are distended. Here the different type of lymph nodes, they are not palpable. They are important because there are many diseases which are mimicking the COPD. You have to really rule it out also. And here gynecomastia, bilateral gynecomastia. And then the lower limbs, inguinal and the popliteal lymph nodes were negative. They are not palpable, no varicosities, pedal pitting edema up to the mid legs. You have to describe where it is ended. And as well as the no pigmentation, toenails are cyanodes also, but they are not clubbed. If it is clubbed, then it is grade 4 clubbing. So it is maybe possibility of the hypertrophic obstructive type of the pulmonary disease, HOPD that is called. It is associated with the carcinoma of the bronchus also. The back, no skeletal deformity, nothing, scoliosis, kyphoscoliosis, sacral edema was positive. The back muscle hypertrophied and in contraction because they are muscles, in the rectus spinae and lateral dorsi, they are also taking the part. How much extra, pulmonary muscles are taking the part? They describe the severity of the problem. And then we have got respiratory system inspection, form of the chest, barrel shaped, just like this in the photograph you see here. Symmetry of the chest is bilateral symmetrical. The movement of the chest, all respiratory and accessory muscles of respiration were in action. There is subcostal recession. Types of respiration, rate of respiration should be described. It is thoracoabdominal. Although in this case, the male should be abdominal thoracic. Why it is thoracoabdominal? This is another question I will put. You will answer in the end, in the second part of this presentation. The rate is 6 to 28 with your own eyes. Bilateral, non-tender gynecomastia, no pigmentation, and prominent veins on the chest. You have to differentiate between the gynecomastia and another condition, lipocomastia. What is gynecomastia and lipocomastia, and how will you differentiate? This is another question I will put in the end. You have to take, discussion with me because I am the, what is called a ghaib professor in front of you. You don't know I am there, but imaginary professor. You are presenting it to the imaginary professor, and I'm helping to you sort out the problems. The position of the trachea, central movements, bilateral, restricted, and tactile vocal fermenters, although it is not done by anybody, it is very important examination. It is bilateral reduced. In the England, it should be done. In America, they do it usually, tactile vocal fermenters. But in England and Europe, they are doing it. If you are missing this, they will ask you why you missed this. So it should be done. It is global hyperextension in this palpation. It is globally, all muscles, they are coming, contraction are there, and the whole of your palpation, you see that there is the bilateral restricted movements are there, but it is all filled movements all over the chest. And the percussion is bilateral hyperresonant in percussion. Auscultation, the character of the breath sounds are vesicular with the prolonged expiration. The vesicular with the prolonged expiration. And the ventilation sounds and the fine expiratory cracks at the basis of the lung fields and the global sibilant bronchi. Why they have developed expiratory cracks and global sibilant bronchi? This is another question you have to ask. I have to ask you in the end. And the vocal resonance reduced globally in both sides. CV examination inspection, the precordium normal, no visible heart sound in the precordium, pulsation outside the precordium. GAVP should be measured properly, how much it is increased. It is increased. What are the methodology you are using? Look my presentation. It will be clear. You will be clear by this. And the palpation, apex beat, unable to determine, difficult to locate it, although it is present, but you cannot describe it. Not palpable, non-palpable heart sounds and no thrill. Heaving of the right ventricle is demonstrated like this. And auscultation, there is no heaving of the right ventricle now, but it should be demonstrated properly. Auscultation, difficult to appreciate the heart sound. Very difficult, very, minimized, auscultatory sounds are appreciated, but appreciated at this time. Abdominal examination inspection, the abdominal was distended, flanks are protruded, palpation, the liver was 3 centimeters palpable, span of the liver is 9 centimeters, fluid thrill was positive. Remember, normally we have about 7 to 11 centimeters of the span. It is normal, although it is palpable but normal span. This is why it is palpable, but it is normal span. Answer this. The percussion, shifting dullness was present. Non auscultation, the gut sounds were audible. The nervous system, hypoesthesia and the loss of vibration senses lost in the lower limbs. So why this occurs? You have to also answer this question in this patient. What is the possibility? And there is evidence of diplopia due to the right sixth nerve palsy also. But what is the underlying problem which caused this diplopia, sixth nerve palsy? Answer this question. The red flag signs in this patient, this is very important. Every case you have to write this red flag signs. Central and the peripheral cyanosis, tachypnea, orthopnea, tapapnea, finger clubbings are present, smoker, non-diabetic. We don't know the diabetic status now, up till now, and BMI is very much higher, it is 37. There was an Asaka ascites. These are the red flag signs of the disease you are going to diagnose. Taper differential diagnosis on the base of the history plus examination. Now is the CCF, copperman, diabetic nephropathy. These are colored blue. The most probable the complication of the diabetes with the complications of the COPD, copperman, and CCF. Nephrotic syndrome, these chances, CLD, these chances hypothyroidism, least chances, hyperproteinemia, adult Kwashiorkor, least chances. Now request investigation related to the case and make final diagnosis and less management strategies. What are the investigation you want to do? Those attending this tutorial suggest investigation by yourself, I don't know, to the case and justify and answer my previous question which you have asked. Study the measures of management strategies. Study from your book. After completion of the above homework, I will discuss inshallah within 2 weeks, because this is a very important case in your life. If you remember like this, you can inshallah ta'ala will be successful in your future. So this is the presentation of the which is what the patient was admitted in the ward. So on the basis now, first question is on the basis of your history and by basis of your examination and the investigation which you have ordered and they are now coming, what is the final diagnosis? Afterward there will be final diagnosis. And then you go to the management strategies of yours. This is and the advancements nowadays. There also should be known to you. So actually, recent advances. So study from my book, diagnose this case, and answer my questions which I have already asked. There are 4 or 5 questions, and then these questions. So this is a very good discussion, and forever it is. Forever it is. Wama alayna illa al-balagh. Inshallah, we will meet it again after you will study. So I'll give you 2 weeks or 1 week. Study this, and then I will answer, because there is an internet problem. I will say that if it is possible, we can discuss. Assalamu alaikum wa rahmatullahi wa barakatuh.